Rick, the floor is yours.
Ladies and gentlemen, good morning. Dear Chairman, thank you for the opportunity to show us the study I did together with Jan. I also would like to thank our colleagues of the Department of Anesthesia here in Aalst for their support. First of all, I want to apologize because I sometimes have a nasty cough. It was a present from my son. Well, we talk about depth of anesthesia, but that may not be completely appropriate. Depth refers to something like a submarine that can move around at different depths, but a patient may not be like a submarine. Some of our anesthetic drugs have very steep dose-response curves, so it may be more something like an on-off phenomenon. What about anesthesia? Even today, on this meeting, very smart people are still investigating and debating about what is consciousness and what is anesthesia. While I consider myself not smart enough to participate in all these highly theoretical and mathematical discussions, I still want to know whether my patient has received enough opioids to wake up comfortably, and that remains a very difficult issue. This is something we do know. This abstract won an award at an ESA meeting a few years ago, and they proved that drug interaction models like the SMARTPILOT were better predictors of response to a certain stimulus than any current device to measure depth of anesthesia. That is why we use the SMARTPILOT to keep our patients at a specific and stable NSRI with different effect site concentrations of an opioid. These are the devices we used in our study: the ANI from M. Doloris, the QNOX QCON from Quantium Medical, the BIS from Covidian Medtronic, and the SMARTPILOT from Draeger. The ANI and the QNOX, as you now know, focus on nociception. The QCON and the BIS focus on hypnosis. Of course, there are other devices, and we will do some more testing in the future, but the space on a patient's forehead is limited. We used RIK Loop software to collect all the data in real time. This was our first experience with RIK Loop, but we are planning to use it in all our upcoming studies. RIK Loop has another feature which we didn't use so far. It allows to make calculations of effect site concentrations. We may be using that in the future as well. Thanks, Jan. You know all the shortcut keys in Microsoft Excel, and you're using them very frequently. Thanks. We experienced some problems. It was not always easy to get the right patient in the right theater with the right anesthesiologist. The urology department came up with a different study interfering with ours, and we experienced every possible technical failure. Also, with some of the devices, in the beginning we had a lack of experience. But thanks to the support of all the companies, we are now able to use all these devices and to collect all their data simultaneously. All our patients were scheduled for robot-assisted radical prostatectomy. We collected data while they were in steep Trendelenburg position and while there was a stable surgical stimulation. We collect and recorded hemodynamic data, but since we consider hemodynamics a poor indicator of anesthetic depth, we will not further mention them in this lecture. After all our setbacks and after a first inspection of the data, we were able to keep the data of 8 patients for further investigation. And this is what we did. With an remifentanil effect site concentration of 1, 3, and 5 nanograms per milliliter, we set and adjusted our target for end-tidal concentration of desflurane in order to reach and to keep an NSRI of 5. When the NSRI was 5, we let all our depth of anesthesia monitors run for 20 minutes and recorded their readings every 5 seconds. The goal of our study was, while keeping the NSRI constant and thus remaining on the same isobol, can any of our depth of anesthesia monitors reveal that we are giving more or less opioids, and perhaps without a SMARTPILOT, can they help us titrating our opioids? This is a little image to help you for the color coding we used in the next slides. The yellow sun shines on the green mountain, and below in the valley runs a blue river. All the data you will see in yellow are data recorded when the remifentanil effect site concentration was 1 nanogram per milliliter. All the green data are recorded when the remifentanil effect site concentration was 3, and all the blue data are recorded when the remifentanil effect site concentration was 5 nanograms per milliliter. These are the entitled desflurane concentrations required to keep an NSRI of 5 with a remifentanil effect site concentration of 1, 3, and 5 nanograms per milliliter. The thick line you see in this and the next slides is the median value. Perhaps you noticed that with increasing opioid effect site concentrations, there seems to be less variability in the entitled desflurane concentrations required to keep a stable NSRI. These are all the data we required for our depth of anesthesia monitors. In the next slides, we will tear them apart into pieces that are maybe a little bit more digestible. These are the ANI of the ANI data. From the ANI data we recorded, we cannot discover a clear effect in relationship to an increasing opioid effect site concentration. This is 1, 3, and 5 nanograms per milliliter. The QNOX data, there's a slight decrease in the QNOX with increasing opioid effect site concentration. But you may perhaps notice there is a high patient variability. There's a very tiny increase in the BIS. Maybe it does not have anything to do with the increasing opioid effect site concentration, but with the decreasing end-tidal concentration of desflurane. The QCON remained quite stable, or maybe there's a very small decrease with increasing opioid effect site concentration. Thanks to our black belt in Microsoft Excel, I can even show you the data for every individual patient. These are ANI data, or ANI data, sorry. These are the data for the QNOX, for the BIS, and for the QCON. I'm very sorry I have to show you these slides really fast, but anyone is welcome to visit us at a later time to have a closer look at them. Anyone is welcome. Should we speak about analgesia or about anti-nociception? Some prefer to speak only about arousability. If you cannot really define it, then how can you measure it? Most of us will agree that the analgesia monitors, the so-called analgesia monitors we use, are not to be used as standalone depth of anesthesia monitors. But from the data we recorded in our study, we don't see they are very useful for proper opioid titration. What you can say about the BIS and the QCON is that they confirmed what the SMARTPILOT claimed and predicted. By increasing your opioid effect site concentration and decreasing your end-tidal concentration of desflurane, you can still have the same probability of response to a certain surgical stimulus. As to titrating opioids, from the data we gathered, neither the BIS or the QCON gave us any useful information. Smarter people, like the ones over here, tried to do more complicated calculations on EEG signals, but were still not able to use them for proper opioid titration. We used very different depth of anesthesia monitors. They measure different things, or they use different algorithms to make calculations on these measurements. Furthermore, we compared them to data from a visual drug display that does not measure anything at all. It makes calculations based on effect site concentrations. So what can we conclude? At first sight, not much. Our small sample size does not allow big conclusions. Furthermore, we did not do any statistics. But in the case of depth of anesthesia monitors, it is not a matter of performing statistically. It has to perform for an individual patient. However, we reduced our end tidal by 50%. This was very easy by increasing the opioid effect site concentration. We used less inhaled anesthetics, and wake-up times will be considerably shorter, certainly in combination with remifentanil. Perhaps you don't really need a SMARTPILOT to do this. The BIS and the QCON can help you to keep your and your colleagues' nerves under control. Another interesting feature that needs further investigation is that we noticed that with increasing opioid effect site concentration, there seems to be less variability in the end tidal concentrations needed for the same effect. Maybe one could say that with increasing opioid effect site concentration, MAC becomes less age-dependent. Maybe. As in other studies, also in our studies, the depth of anesthesia monitors were not good enough for proper opioid titration. So, today, in our opinion, visual drug displays remain the golden standard. They do not take into account patient variability, but they give you a clear view on the hypnotic and nociceptive component of your anesthetic. Furthermore, their predictive properties remain unbeaten. More important than any conclusion, I hope this will lead to interesting discussions and questions. Thank you.